Hey everybody, welcome back to Spot Check here. We have chapter 2 of Spits on our hands here, Disorders of Pigmentation. Also want to start out giving a big shout out to Miss Santoso here. She's an up-and-coming med student who is super excited about what she did here, and if you want to give her a nice thank you down in the comments below, let her know that she's appreciated. That'd be awesome. Lots of diseases to go over here. Big lecture. Lots of high yield ones, some not so much. Some you might have heard of before. So let's go ahead and get started with this. We're going to talk about oculocutaneous albinism type 1. So oculocutaneous albinism type 1 is an autosomal recessive TYR gene mutation. The mutations are in the TYR gene, so that decreases the tyrosinase activity to near zero. You still have a normal number of melanocytes, but they are unable to produce melanin in the skin. So when you look at the type of melanosome components, you're only going to see stage 1 and stage 2 pre-melanosomes in the melanocytes. Also with this, you're going to see occasionally some miswiring of optic fibers. So here's a mechanism that kind of helps break down what's tyrosinase's role in terms of synthesizing vesicles to then transport out. So you're going to see that it accumulates a few different products as it goes through the endoplasmic reticulum. Not incredibly high yield for the disease state, but more for if you're interested in learning about the biochemistry of it. Do note that OCA type 1 is a mutation in the tyrosinase gene with either complete absence, which is 1A, or reduced absence, or reduced, gene in 1B. You can also have OCA2, where the mutations actually reduced melanin production. So you often see some milder symptoms with that. Both of these are recessive. So here's a table here to kind of break it down as well, the different types of oculocutaneous albinism. Type 1, note that you're tyrosinase negative. So either the tyrosinase gene is absent or reduced. Type 2, or tyrosinase positive albinism, has mutations in the P gene, so positive in P, and that encodes a pH regulating protein that supports melanogenesis. Most common type is type 2, and that's when you have a decreased melanin in the skin. It's usually less severe. You get more of a creamy white skin, light yellow, blonde, or light brown hair. There's also a type 3 albinism. That is a mutation in the TERP gene, TYRP1. Usually this is called like rufous oculocutaneous albinism, where you get like reddish brown skin, ginger red hair, hazel or brown irises. So not quite the light hair, blue-eyed with the other two. So this is it's a mnemonic. You can try to use it. It's tough to get to, but it's try to pee and trip on a slick mat. Try for tyrosinase, the two mutations in type 1 OCA1 and type 2 or type 1B OCA1. The 2P you can think of as the OCA2, which used to be the P gene. TRIP, also for type 3 OCA. And then one we didn't talk about yet, type 4 OCA. Typically 25% Japanese individuals get this. Not 25% Japanese, but the incidence, you see this higher in the Japanese population. And this mutation is the SLC45A2 gene. So what do we see with, at least specifically OCA type 1? We see skins generally pink-white. You have often solar keratoses, skin damage, pink-red nevi. You're likely to get some skin cancers with this, obviously. So you have a high incidence of squamous cells, and then basal cells, and then melanoma. You're almost guaranteed a squame, so it's just a matter of when. Snow white hair, blue to gray, blue irides, impaired visual acuity as well. As we talked about earlier, there's some sort of optic neuronal component that's not quite up to snuff, if you will. The differential obviously goes down any type of golden hair pigment disorder, white hair pigment disorder, as well as the other OCAs. We figured this out with DNA analysis now. Real easy stuff. So let's go into OCA type 2, or tyrosinase positive oculocutaneous albinism. This is an autosomal recessive disorder. It consists of the P gene mutation The basically the pathogenesis here is that you're still tyrosinase positive, but mutations in the P gene decrease melanin synthesis. This gene product might actually play a role in like tyrosinase transport. Therefore, you have decreased melanin in the skin, hair, and eyes, and as well as an ocular component to this as well. Your hair is more of a pink, white to cream colored, little more, I guess, towards the reddish side of the spectrum than OCA type 1. You have multiple pigmented nevi, ephlids, lentigenes, solar Ks, SCCs, BCCs, creamy yellow brown color, blue to yellow brown irids. Differential diagnosis here, obviously similar to the last, and mutation analysis is how we figure this out. For both of these diseases, you're going to need to do sun avoidance, long sleeve t-shirts, brim hat, broad spectrum UV protection. You need to see a dermatologist because they're going to get screened. It's not a matter of if you get a skin cancer, but more likely when. The eyes don't have as much pigment in them either, so you do need some UVB protecting sunglasses, corrective lenses, and a referral to the ophthalmologist as well. Here's another example, just kind of comparing the two. OCA type 1, whether it's type 1A or type 1B, you're going to have pink to white skin, snow white hair, light color irises. And type 2, you're going to have OCA type 2, obviously, reduced melanin production, more common, milder symptoms, a little bit more pigment in your hair. Hermansky-Pudlak syndrome. So on the spectrum of light-haired diseases, right? Autosomal recessive here. The gene locus is the HPS1 gene. It is found often in Puerto Rican small villages. There's other genes too, HPS2, or also known as AP3B1. So there are a couple other findings that you'll see, other genes that are implicated. Not many incidences are reported, like 200 cases, and they kind of seem to be from some local populations. So here's some pathophysiology, biochemistry for you. Right here, you're going to see a duplication mutation in HPS1 gene. That's important in protein localization. So that's how your organelles do intracellular trafficking. You also have the AP3B1 gene mutations, which impair the AP3 adapter complex, protein packaging, vesicular formation, membrane fusion, how proteins are shuttled through and between cells. Bleeding diatheses are secondary to platelet storage defects and decreased ADP and ATP and serotonin granules. So therefore, without those protein products, you're impairing platelet aggregation. You also will see lysosomal membrane defects and accumulation of steroid lipofuscin and macrophages. You're going to see a pigment dilution, not without pigment, but pigment dilution. That makes you more susceptible to actinic damage and things that come thereof, as well as the added benefit of, or added negative of, ecchymoses and petechiae. Other things you can appreciate: photophobia, nystagmus, strabismus, epistaxis, gingival bleeding, menorrhagia, prolonged bleeding during childbirth, dental extraction or surgery, the steroid depositions and macrophages as well. And this can have some long-term effects to them. They can have pulmonary fibrosis from this. You can have granulomatous colitis or even cardiomyopathy. So some laboratory data outside of DNA mutations that might be beneficial. You'll have a bleeding time that's prolonged. So both prothrombin and partial thromboplastin, PT and PTT. But the platelet counts will be normal, right? Because the defect is in the granules of the platelets and not the platelets themselves. At least the production of platelets. So some things to be aware of course, in anything where you have a propensity to bleed, you should avoid aspirin. Aspirin has a half-life of 7 days because that's the average lifespan of a platelet. So be mindful of that, avoiding aspirin. Pulmonary function tests and colonoscopies are paramount. It doesn't make perfect sense, just looking at the name and thinking about what it does, but you have to think downstream. These proteins are then aggregated, non-functioning, in parts of high replication. That includes epithelium, whether it's lung and colon. So you're going to have some downstream effects from pulmonary fibrosis and granulomatous colitis. You're going to need to see a dermatologist, hem-onc, ophthalmologist as well, especially if you have the eye findings. And then let everybody know that may or may not do some sort of surgical procedure on you. You will have some issues bleeding. Usually, if you do have a complication from this, it is a hemorrhage, colitis, pulmonic disease, or a aggressive skin cancer like squamous cell. So here's another photo just about some of the downstream complications from Hermansky-Pudlak. All right, let's go to Chediak-Higashi syndrome. Chediak-Higashi syndrome is an autosomal recessive disorder of the List gene. What you can do one way, outside of genetic analysis, obviously, but you can also prenatal diagnosis through like fetal hair shafts, and you'll see some large clumping of melanosomes under light microscopy. You can also see neutrophilic granules on fetal blood. Incidence is rare. Another one of those cases where only 100 or so reports at the time of at least the reference that we used, but nonetheless just still something you know. In fact, many of you might have seen this as you study for medical school. The pathogenesis includes, so the List gene mutation leads to accumulations of giant lysosomal granules in neutrophils, melanocytes, and neurons. So, like we said, List gene, List for lysosomal tracking. It says in the name, it's awesome. That regulates microtubule-mediated lysosomal fusion and fission, as well as protein sorting. So this defect leads to accumulation of giant lysosomal granules in a variety of cells. So you'll see this in neutrophils, melanocytes, neurons, most notably. Platelet storage pool deficiency also, so you'll have a bleeding diathesis. You can also have decreased natural killer cells and antibody-dependent cell-mediated cytolysis function. So here's a good example of a pathophys again, when you have functional List and abnormal List, some of the cells that are affected. So you're going to see giant clumps in neutrophils, giant clumps in NK cells, cytotoxic T lymphocytes. You'll see fewer granules and platelets, and then their subsequent downstream effects, which should make some sense. Some other things to remember. Here's something that kind of helps put some pieces together. Thank you to Creative Medosis for letting us use this. And we're going to continue on. So key features here. You're going to notice a light cream to slate gray color. You're going to notice recurrent bacterial infections, and that comes from defective granules in your immune cells. All right, so defective granules in your immune cells means that you're not adequately attacking infections. You're going to see a light blonde hair with a silver sheen. You're going to have photophobia, strabismus, nystagmus. You'll notice that you're going to have recurrent infections, bacterial sinusitis, pneumonia. You might even develop an ataxia, muscle weakness, sensory loss, seizures, etc. Unfortunately, there's an accelerated phase component to this, and this is when you have a lymphohistiocytic proliferation, and that's within the large organs, liver, spleen, lymph nodes. With this proliferation, you'll have an anemia, neutropenia, thrombocytopenia, so then you can have massive, overwhelming bleeding and infection. And this happens reportedly in 85% of patients. The mnemonic here, so think of Chediak-Higashi, Sir Chediak-Higashi bringing in his list of demands, LYST obviously for the lysosomal trafficking protein, and then in that list it's in alphabetical order, LMNOP, so lymphohistiocytosis, microtubule dysfunction, neurologic symptoms, phagolysosome, pancytopenia. And then here's an picture depicting all the affected areas with Chediak-Higashi syndrome. So how do we differentiate Chediak-Higashi from Hermansky-Pudlak now that I've gone through both? So you can differentiate these because Hermansky-Pudlak is more silvery hairs and the platelet defect is less severe, where Chediak-Higashi has a devastating platelet defect. It also has the accelerated phase, etc. So those are kind of some things that can help narrow it down a little bit. The Chediak-Higashi, obviously, you all need to refer to hem-onc. They're going to need a bone marrow transplant more because of the propensity of those disastrous outcomes that happen 85% through the accelerated phase. Chemo, high dose of ascorbic acid as a protective agent, referral to derm, ID, immuno, neuro, ophthalmology. All right, let's move on to Griscelli syndrome. Griscelli syndrome here, autosomal recessive. You can do a fetal scalp biopsy, but so much of these are anticipated through DNA analysis that those techniques are becoming outdated. Mutations in gene encoding for myosin V or myosin 5A or the RAB27A genes. Proteins involved mostly are organelle trafficking, membrane transport. You can also have a melanophilin gene mutation, which is in a subset of patients. Ultimately, three main types here with mutations in the myo5A, RAB27A, and melanophilin MLPH gene, respectively. Each one presenting a little bit different. We're going to break down some of the nuances here, but overall, very similar. What you'll notice is patients with the myo5A mutation have a primary neurologic impairment, but not so much the hemophagocytic syndrome, while patients with the RAB27A have the hemophagocytic syndrome and rarely develop neurologic involvement. And if they do, it's usually secondary, so it's caused by lymphocytic infiltration of the CNS. You're going to see a pigmentary dilution, cutaneous pyogenic infections, abscesses, silvery gray hair, neutropenia, thrombocytopenia, no leukocyte inclusions. With Griscelli syndrome, you're going to see large clumps irregularly spaced in the melanin pigment. That's big. A lot of these things are going to ask you, look at this. What is this? And that's one of the keys with Griscelli is that you can see these large clumps on the hair shaft. Griscelli syndrome has some key features here, such as immunologic, where you have lymphohistiocytic infiltration, that's hepatosplenomegaly, as well as combined T and B cell immunodeficiencies. You can often see also an accelerated lymphoma-like phase. You can see infectious disease etiologies, such as episodic fever with or without infections and pyogenic systemic infections. Of course, you can have neurologic components as well. On the differential is El-Holiday syndrome, and I apologize if I butcher that, but El-Holiday syndrome, it looks like Griscelli syndrome from a pigmentary standpoint, but there is severe neurodysfunction and no immunodeficiency. So that's the key. No immunodeficiency and severe dysfunction. El-Holiday syndrome looks like Griscelli syndrome, but it is a severe additive neurodysfunction and no immunodeficiency. So it looks arguably similar to GS1, but more severe neurological development. Chronic granulomatous disease, you can have that on your differential, OCA2. Hair-wise, you'll notice uneven clumps of melanin. We talked about that in the medulla, the hair shaft on light microscopy. You'll also notice absent cytoplasmic inclusion bodies and neutrophils. Referrals here, going to hemonc, getting that bone marrow transplant. You're trying to avoid that accelerated like lymphomatous phase. Referral to ID, neuro, and dermatology assists, usually in the diagnosis, but thereafter you don't have much of a role as well. So we got piebaldism here next, also known as familial white spotting. Piebaldism, inheritance here is autosomal dominant, mutations in the c-KIT proto-oncogene. You'll notice here that the mutation in the c-KIT proto-oncogene results in abnormal tyrosine kinase transmembrane receptors that decreases signal transduction and causes abnormal melanocyte embryogenesis. Therefore, you have defective melanoblast proliferation, migration, and distribution, which is responsible for kind of the splotchy loss of pigment, like the example on the right here. You'll notice in the skin depigmented patch. So not just hypopigmented, depigmented patches on the mid-forehead, central eyebrows, neck, anterior trunk, mid-extremities, etc. You'll have islands of hyperpigmentation, and that's normally within or at the borders of the hypopigmentation. You'll see that white forelock. You'll see also rarely Hirschsprung disease, mental retardation, deafness, and cerebellar ataxia. On your differential here, Wardenberg and vitiligo nevus depigmentosis. Histology from depigmented areas reveals basically absent melanocytes and melanin altogether because it is a depigmentation, not a hypopigmentation. Through management, you're going to notice that you can do autologous cultured melanocyte grafts. Ultimately, you're going to need sunscreen heavy, especially in those areas of depigmentation because you have no UV protection. Some people do like a camouflage type where you do hair dye, you can dermablend, 20% topical monobenzyl ether of hydroquinone maybe would be effective. And a good way to kind of remember it is, you know, you can create, you know, you get a pie baking kit, and you want a big pie, so you get the dominant kit, you get the large kit. But when you notice is, and I don't know, I worked at a grocery store, and every time I got those pie crusts, they were always broken. So usually it was the bigger pie crusts. So it might have been because I threw them into the freezer and maybe not took great care of them as I should have. But those broken pie crusts have missing pieces. So here, especially in your big pie kits, the dominant versions, you're going to have missing pieces. Picture that lightning bolt right there where the head of the pie would be, if you will. Moving on, we have Waardenburg syndrome here. Waardenburg syndrome is an autosomal dominant PAX3 gene mutation. Other things are implicated though, so include MIDF gene and the SOX10 gene, as well as the endothelin 3 genes, respectively. So mutations, there's 4 distinct types. The 4 types of Waardenburg are listed here: type 1s, 2, 3, and 4, and the genes implicated are associated with them. So you'll notice type 1 PAX. So there's a little like cute little saying you can say like PAX your mitts, PAX your socks, and that goes in order from type 1 to 4. So type 1 PAX your mitts, mitts type 2, PAX type 3 on the repeat, your socks type 4. Some people even add a little bit of a cheer with that, where you could talk about, you know, your first PAX will be touching your eyes, your second PAX will be touching your ears, your second mitt will be touching your ears, your third PAX will be touching your arms, and your fourth socks will be touching your belly area. And that associates with the relative functions that are impaired. Do note that SOX10 can be, you know, isn't the only sole mutation. You can also see endothelin 3 mutations or endothelin receptor gene mutations in type 4 disease as well. So why do we do that little cheer? So PAX, putting it on your eyes, that helps you remember that there's wide space eyes, dystopia canthorum, as well as a broad nasal bridge. When you put on the mitts part of your cheer, the ears, PAX your mitts, you're covering your ears, you have a moderate to severe hearing loss. And then PAX, you're touching your arms, it's because you're going to have bone growth abnormalities in your hands and arms. And then when you say your socks, you're going to be putting your hands, you're going to be touching your intestines, your stomach, right? And that helps you relay that type 4, not only is the SOX gene mutation, but also a intestinal blockade. So PAX your mitts, PAX your socks. Of course, you can also see a white forelock in this. You can see synophorus, broad nasal root, dental caries, depigmented patches on the body, dystopia canthorum, in almost all of them except not type 2, obviously, and we didn't touch our eyes on type 2, we touched our ears, so that makes sense, right? We're not going to see that with type 2. You'll also notice that you have heterochromia irises, as well as hypopigmented fundus. Your ears in type 2, mostly, you're going to have a congenital sensory neural hearing loss, not exclusive. Colon, you can see Hirschsprung, usually isolated to a type 4. That's why we touch our stomach with type 4. You can see cleft lip and palate, pectoral, upper limb abnormalities, etc. Differential diagnosis: piebaldism, Vogt-Carnagi-Harada syndrome, vitiligo, Alexandri syndrome, as well as a little formula here that can help you calculate dystopia canthorum. Referrals are going to go where you need them. So it depends on the type of mutation you have, and then you're going to refer to the specialist with that specific care in mind. So just as a little refresher, I know we talked about it ad nauseum, what are the 4 types of genes associated with Waardenburg? So if you're not saying PAX your mitts, PAX your socks at me, or at least skipping this part of the video, then we'll go over it one more time. So you'll type 1 and 3, PAX, type 2, MIDF, type 4, SOX10. PAX your mitts, PAX your socks. Cool? All right. Now we're going to do hypomelanosis of Ido, also known as incontinentia pigmentia chromianus. Inheritance here, not necessarily inherited. So you have a mosaicism with this. It's usually a chromosome or single gene mutation. Many different phenotypes are present because it's not a classic tried and true, this gene is always mutated type disease. You'll notice that you have unilateral and bilateral world marble cake-like appearance, which is hypopigmentation, especially in the lines of Blaschko. The lines of Blaschko are your embryonic lines. So that gives you an idea, hey, this might be a mosaic thing that's going on. You can also see some alopecia here as well. Other associated findings include central nervous system, so you can have seizures, some retardation. In your eyes, you can have strabismus, hypertelorism, musculoskeletal, you can have a scoliosis or a limb length discrepancy. Teeth, you can have anhedonia and dental dysplasia. Big differential here. I think it's important to kind of keep in the back of your head, but with this disease state can stand out to you pretty well. You want to do a complete physical, that way you can see if you can catch any of those underlying abnormalities that may or may not be associated with the areas of depigmentation. You're going to have to put them you're going to have to associate them with the subspecialist necessary based on the abnormalities you find. And then you can talk about some camouflage cosmetics to help minimize appearance. Okay. High yield disease here. Important. Turn on the brains. Get the listening ears going. Take the mitts off. We're going to talk about incontinentia pigmenti. This is an X-linked dominant disorder. So incontinentia pigmenti is a X-linked dominant disorder in the NEMO gene. Over 700 cases reported. Mutations in NEMO, which is an NF-beta essential modulator, leads to defective NF-beta activation. NF-beta is a transcription factor essential for several inflammatory, immune, and apoptotic pathways. So ultimately here, and I mean, you've also heard of NF-beta as NF-kappa B, right? So X-linked dominant, male lethal syndrome. So you're typically only going to see this in female patients or the rare, very rare Klinefelter patient, XXY. IKBKG. This is the new way they name NEMO. So formerly known as the NF-kappa B gene, the IKBKG gene. It's on the X-linked chromosome. It does modulate NF-kappa B. This gene basically regulates cell division to a degree and programs cell death, so mutations cause an increase in apoptosis. Cell death in the skin may present with blisters and also affects endothelial cells in the brain, which can cause seizures. The stages are incredibly important. Knowing the timeline, how they appear, and what appears is often how people will test you on this disease. Stage 1 is a vesicular pattern where you see it early in the first 1 to 2 weeks after birth. Classically marked as vesicles and bullae, and usually in linear arrangements. Stage 2, a few weeks later, verrucal stage. You're going to see streaks of hyperkeratotic papules, pustules, mostly on the extremities, and they're going to be in that streak-like pattern. Stage 3, hyperpigmentation, 3 to 6 months, whorls and swirls of hyperpigmentation, and this is along lines of Blaschko. Stage 4, big gap here. So you went stage 3, 3 to 6 months. Stage 4 is 2nd to 3rd decade. Hypopigmentated whorls and swirls. So stage 1 vesicular, 2 verrucal, 3 hyperpigmented, 4 hypopigmented. Now the hypopigmented will typically replace the hyperpigmented, but that's not exclusive. And you may or may not have follicular atrophy in the same areas, but not exclusive to those areas. Here's a good example of each stage here in action. Hair. Hair, you're going to have often a scarring alopecia. You can see some nail changes. Teeth, you'll see anodontia or peg/conical teeth, and that's a little more common. Eyes, you can have strabismus, cataracts, optic atrophy, retinal vascular changes, secondary blindness, retrolental masses. And then as well, you can have concerns with seizures, mental retardation, spastic paralysis. And then here is another depiction of the various stages as well. So this is one of the few times where you don't need derm path, but it does have some pretty unique derm path findings. And it's typically only the vesicular stage. So you'll notice here in the vesicular stage, you're going to have a significant eosinophil predominance in your spongiosis here. So, and you might even also notice a peripheral eosinophilia on a CBC. So that's the one thing I want you to kind of take away from here. There is on derm path a strong eosinophilic predominance on specifically vesicular or bullous stage IP. And they're going to need referred to everywhere that's affected. Remember, the most common things affected are teeth, so peg teeth, conical teeth, seizures, and lens issues. All right. So now we're going to talk about leopard syndrome. It's not often called leopard syndrome right now. It's more called Noonan with multiple lentigines or multiple lentigine syndrome. But leopard helps you, unfortunately, remember the various characteristics with the disease. So it's an autosomal dominant mutation in the PTPN11. So it's like you're petting. It kind of sounds like petting. You're petting your pet leopard. So a way you can try to memorize that. This mutation, the PTPN11 gene, encodes the non-receptor protein tyrosine phosphatase SHP2 and is implicated in Noonan syndrome. That's why there's this overlap, Noonan with multiple lentigines versus classic Noonan syndrome. Skin, you're going to see generalized multiple lentigines. Mucosal membranes often are spared. Cafe noir spots, cafe au lait spots. Cardiovascular, you're going to see EKG abnormalities. You're going to see pulmonic stenosis. You're going to see ocular hypertelorism. And look, we're even doing you a favor here. We highlighted the L, we highlighted the E, O, and the P. We're starting to spell out leopard here. Of course, clinical pearl here. If you see someone with multiple lentigines, you're going to need to send them away for a cardiac evaluation. All right, let's fill in the rest of the leopard here. Abnormal genitalia for A. Growth retardation here for R. And sensory neural deafness for D. So here they are spelled out for you. Do note, obviously, if you have multiple lentigines, you're going to need a cardiac workup. You could also loosely biopsy these spots because sometimes a nevus from a F-lid from a lentigine is difficult to kind of ascertain. All right, let's go on the Carney complex here. Also known as name and Lamb syndrome, depending on the phenotype presentation. So Carney complex, it's an autosomal dominant PRKAR1A gene. Also, we kind of butcher it and say Pakar gene. Pakar sounds like a caw from like some sort of bird. So you can be at a carnival for Carney, seeing the abnormal bird and its trainer doing caws that sound like Pakar, right? Incidence here is rare. You see it slightly higher in Jewish populations. The mutation in the Pakar gene is a tumor suppressor gene, and that encodes the regulatory subunit type 1A of the protein kinase A. So here is a good way to kind of depict, we have a certain subunit out, so we might not be able to cycle through the G-coupled receptor proteins downstream products quite as readily. So Carney complex, you can also see it often named as name syndrome or Lamb syndrome, and that kind of helps isolate through a mnemonic what findings are specific in that presentation, that phenotypical presentation. For example, name syndrome here, nevi, atrial myxoid tumors, and F-lids. So some things that you might see that coincide with either name or lamb. Blue nevi, you can see melanocytic nevi, F-lids, cutaneous myxomas, atrial myxomas. You can also see, depending on organs affected, you can see Cushing syndrome, pituitary adenomas, testicular tumors, or actual sexual precocity. Pseudomonas melanocytic schwannomas can be seen. Do note that on the differential here is Leopard syndrome, Peutz-Jeghers syndrome, Lamb syndrome is a part of this, and I feel like we didn't talk about as readily Lamb syndrome. So know that lentiginous, atrial myxoid tumors, and blue nevus is the B in Lamb syndrome. Referral to those that need it. So the one that you want to keep on mind here is a cardiac or atrial myxoma. So you're going to need to see a cardiologist for evaluation. Every now and then you can actually throw clots from a myxoma, as well as the myxoma can block some part of the outflow of your heart, causing some downstream deficits. All right, let's get back to this. Which of the following is not part of the Carney complex here? PEG conical teeth, cutaneous or cardiac myxomas, some pigmented skin lesions, endocrine abnormalities, primary pigmented nodular adenocortical disease. Which one of these have we not mentioned yet, or was not in either a mnemonics name or lamb? Right, PEG teeth. So PEG teeth, you got to remember, 66% of the time are found in IP, okay, as well as some ectodermal dysplasias, which you didn't necessarily talk about in this chapter. McCune-Albright syndrome. So McCune-Albright syndrome is a sporadic post-zygotic somatic mutation in the GNAS1 gene. Pathogenesis here, so you're going to have a mosaic distribution, so you might see some unilateral findings. The mutations in the GNAS1 gene, so that is a stimulatory G protein product that regulates adenylate cyclase here. So here's a good example of adenylate cyclase maintenance here, as well as maintenance of how this downstream affects like growth hormone, etc. So these sporadic GNAS mutations lead to mosaicism. You can have a hyperfunctioning endocrinopathy from this, which includes increased melanin, E2T4 for thyroid growth hormone, cortisol, and therefore you can see things such as hyperthyroidism, Cushing syndrome, and acromegaly. Key features here in McCune-Albright syndrome with skin, you can see cafe au lait macules, considered coast of Maine bordered. You'll also see polyostic fibrous dysplasia, so long bones and facial bones are most commonly affected, and that's usually underneath the pigmentary deficit or the pigmentary change. So cafe au lait macules can signify which bones might have polyostic fibrous dysplasia or some lucency. Therefore, you'll see as a result of this frequent fractures and bowing of the limbs. You might even see a diffuse sclerosis at the base of the skull, and of course, pigmentary deficits through precocious puberty, more in females, or hyperthyroidism. Cafe au lait spots. So one thing that should be on your differential is NF. Something to definitely get an eye on. And laboratory data for this should be focused on endocrinopathies as well, because you have to isolate the endocrinopathy when you have a suspicious diagnosis for this disease, if there is one, in terms of endocrinopathy. So orthopedist surgical correction for those bone deficits, referral to endocrine. You might need to start a selective hormonal agent based on the hormonal outcomes thereof. So here you're going to notice we have isolated hyperthyroidism, and that's independent of GnRH. You can have precocious puberty, increase in estrogen, cafe au lait macules, and polyostotic fibrous dysplasia. Neurofibromatosis type 1, high yield here. I don't have to tell you guys that. You guys learned about this in medical school most likely, or at your professional schooling, but something to kind of be on the lookout for, more common, some downstream effects you'll notice with it. You'll also hear it called von Recklinghausen disease, 17 letters, because this is an autosomal dominant mutation on the 17th chromosome, okay? You can also see some spontaneous mutations here in 50% of the cases. 1 in 3,000 incidents with varying, clinical phenotypes. The pathogenesis here, you have neurofibromin, which is the gene product of NF1, and that is a tumor suppressor gene. It usually dampens products of the RAS proto-oncogenes downstream so that you don't have overproliferation. Therefore, a mutation in neurofibromin protein has unchecked RAS. So therefore, its loss will contribute to tumor progression. Skin-wise, you're going to see cafe au lait macules. You're going to see increases in the number and size, especially in the first 5 years of life. If you have greater than 6, that suggests NF1. You're going to see freckling in the axillary or inguinal folds. You're going to see neurofibromas, dermal, subcutaneous. You could see plexiform, congenital ones. And often, sometimes you can even consider yourself, these kids are born with the plexiform and the fibromas. They just don't become clinically prevalent until a few years of life. And you can have pruritus on the overlying a growing neurofibroma as well. Eyes, you're going to see leash nodules. That's high yield. 90% of patients, especially older than 6 years old, will present with leash nodules on the iris. You'll also see congenital glaucoma in these patients, choroidal nevi. You can see an optic glioma in this 66% of the time, mostly asymptomatic, but do still need to be monitored. Also consider astrocytomas, meningiomas, vestibular schwannomas, ependymoma. You can see neurofibrosarcoma, rhabdomyosarcoma, pheochromocytoma, Wilms tumor, non-lymphocytic childhood leukemia, visceral neurofibromas. Skeletal defects, you'll see a sphenoid wing dysplasia. That's one that's kind of hidden, but still high yield. So sphenoid wing dysplasia is associated with neurofibromatosis. You could also see the dysplasia of the thoracics, usually cervicothoracic kyphosis or scoliosis. Gastrointestinal disease, constipation, a little bit weak. There is a psychiatric burden, especially if you have a proliferation of neurofibromas. I mean, if you have a lot, it can actually be quite devastating to your psyche. Vascular wise, you can have vascular dysplasia, especially in cerebral or GI or renal organs as well. And here's a little cartoon to kind of help isolate a lot of the common findings here. For diagnosis, the NIH consensus criteria in 1987 has the following that can help you diagnose NF type 1, and that's 6 or more cafe au lait spots over 5 millimeters in diameter. That is especially in prepubertal individuals, and over 15 millimeters in the greatest diameter in postpubertal individuals. You could have 2 or more neurofibromas of any type, or one plexiform neurofibroma. You can have freckling in the axillary or inguinal regions, optic gliomas, 2 or more leash nodules. You can see a distinctive osseous lesion such as sphenoid dysplasia or like a thin long bone, pseudoarthritis, or you can have a first degree relative with NF1. Differential is wide on this, obviously, because there's so many findings that can overlap with other diseases. Management here, good history and physical as well as family history, baseline ophthalmologic exam, regular follow-up with everybody involved, ophthalmologist, neurologist. You can even consider plastics depending on some of the neurofibromas and locations, etc. Keep in mind orthopedists as well, because there is often some sort of long bone deformity or scoliosis or that sphenoid wing dysplasia. You can have a shortened lifespan secondary to neurofibrosarcoma, pheochromocytoma, vascular disease complications, CNS tumors as well. And then we'll talk about NF2. NF2 is an autosomal dominant mutation in the SCH gene. The SCH gene is on chromosome 22, so that's a kind of an easy way to remember. NF2, chromosome 22. The NF2 gene product is a product where you have the protein schwannomin or merlin, and that affects also tumor suppressor activity at the cell membrane. Less common than NF1, obviously. There are 3 types of neurofibromas. You can have subcutaneous with overlying pigment or hair. You can have subcutaneous spherical tumors with associated palpable nerves, or you can have an intradermal. That's more in NF1. And then less common in neurofibromas and NF2, neurofibromatosis 2, is the cafe au lait spots. So you might see 1 or 2 lesions, but you shouldn't have the 6, which would be diagnostic for NF1. Key thing with this one, you learned it in medical school, you're going to hear it again now, that's bilateral vestibular schwannomas here, or acoustic neuromas. So bilateral vestibular schwannomas, NF type 2. You can see some of these other CNS tumors which overlap a little bit, NF1 and NF2, but that first one's going to be your key one here. Additionally, you can see juvenile posterior subscapular lenticular opacities. So this one's also going to need an ophthalmologic exam. So we have a criteria for this one as well. If you have bilateral cranial nerve 8 masses, then bingo, bango, bongo, you have NF type 2. If you have a first degree relative with NF type 2, that helps classify you with the addition of at least one cranial nerve 8 mass. You can also have any of the two of the following, which are your kind of your hints towards NF type 2: neurofibroma, meningioma, spinal glioma, or schwannoma. So things that are automatic triggers: bilateral masses, first degree relative with NF. And if you have that first degree relative with NF, it helps to have the unilateral cranial 8 mass. But if you don't have a first degree relative and you have a unilateral cranial 8 mass, then look for some accessory findings like neurofibromas or posterior subscapular lenticular opacities, etc. Referral: you heard it here. Cranial masses require people that are specialized in the cranium. So that can be ENT for hearing deficits, that can be neurosurgery, that can be ophthalmologists, depending on where these masses are and what findings are found. The progressive deterioration in hearing, ambulation, and sight can lead to an early death, as well as CNS tumors that are less specific to this disease can cause a severe disease burden as well. All right, another high yield one you've heard of before most likely, but we're going to talk about one more time here, and that's tuberous sclerosis here. Autosomal dominant in the TSC1 gene. You could also see this in the TSC2 gene. And what you'll notice here is mutations in these genes encode either Hamerton or tuberin respectively, and that interacts with GTPase activities of the RAP1 gap family genes. TSC2 tuberin, renal cysts, you can see renal cysts with tuberin, and may be associated with deletions in contiguous polycystic kidney disease or PKD1. So it just so happens that PKD1 gene is close by to the TSC2 gene, and you can see a concomitant deletion. The features in this are different to a degree from NF1, so it's good to keep these separate. Ash leaf spots are the earliest, most characteristic finding. Those are hypopigmented macules. You can also see polygonal or confetti hypopigmented macules. You can see a connective tissue nesis, also known as a chagrin patch. You could see a facial angiofibroma or adenoma sebaceum, which are periungual fibromas around, the nails, periungual nails. Facial angiofibromas will be on the face. That's pictured up above. You can also see cafe au lait spots, and you can see a fibrous plaque of the face. The name of that has been discussed about getting changed because it doesn't have to be exclusive to the face. But a fibrous plaque of the face is most common or most classic. Eyes-wise, you could have retinal hamartomas. Kidneys, you can have angiomyolipomas, cardiac rhabdomyomas. So you're getting myomas in various places. Lungs, you can have lymphangiomyomatosis, another myoma in another place. You can have other cysts such as pharyngeal cysts, periosteal thickening, oral enamel pits. CNS-wise, you can have infantile spasms, tonic-clonic seizures, some spasms, mental retardation, cortical tumors, paraventricular calcification, subependymal nodules, with or without obstructive hydrocephalus. Differential is large because there's a lot of findings associated with this. You can use some other things to find some of the secondary downstream effects of TSC1 or TSC2 mutations, such as like a Wood's lamp to find hypopigmented, depigmented areas. You could use the CT scan of the MRI of brain to look for secondary CNS findings. EEG is helpful. Fundoscopic exams helpful. Renal ultrasound and echocardiogram as well. You're going to know where to send them based on what findings you have from your workup. The addition is you're gonna consider like a laser specialist, and that's for the facial angiofibromas. So you're gonna need a specialist in CO2 laser for an ablative therapy, as well as referrals to ophthalmologists and refers to other specialists in symptomatic. Premature death usually occurs secondary to cardiovascular complications, so it's important, it's paramount to get them set up with a cardiology team, as well as other findings which can contribute to the morbidity, including brain, renal, pulmonary, and seizures. So again, thanks guys for listening. This is a big chapter. It's huge, thick with two C's here. Lots of high yield stuff in there. Some stuff that you probably have heard of before. So again, give Brianna here a good shout out in the comments if you appreciate what she did. And if you have any other questions, bring them up down in the chat. If you found any errors, any discrepancies, any new research, bring them down in the comments as well. And again, thank you. We'll see you in the next one.